Good morning, dear colleagues. Today I will lecture about depression. I hope now everybody coming. Quality of sound enough. I ask you now as a small speech before lecture. Today very important lecture. Why? Because depression it's it's a disease which has a very high ratio in the populations, and a lot of outpatients in polyclinics suffering due to depressions. Dear colleagues, I ask you check sound and video quality. I ask you type in our Google chat about quality of sound and about quality of video. I wait maybe some second and we continue our lecture. Now I check chat. Quality of sound. Everything is good. Okay, now I receive reply. Okay, now we start our lecture. Today our lecture about depressions. We will discuss about depressions. We are looking glass of the new classifications of mental disorders, DSM-5. I am Professor Alexander Dvirsky, Department of Psychiatry and Psychology. Before start our lecture, we discuss what does it mean depressions, like definitions about depressions. Depressions result of the complex interactions of social, psychological, and biological factors. Pay attention to these definitions. Depressions, it's not only biological diseases. You remember that we discuss about two types of diseases in psychiatry. First type of disease in psychiatry, it's mental disorders. What has been mental disorders? Mental disorders, it's a diseases. It's a problems in behavior and in mental process without general medical conditions. Now some words about mental process. Mental process is something which happy in our mind. Mind it's functions of our brain, and mental process depend our behavior. Mental process it's something like thinking, it's something like emotions, it's something like consciousness. It's like an internal mechanic of our brain. Mental process objective for ourselves, mental process subjective for examiner. It's mean when you doctor-patient relations, doctor only have some opinion about patient's mental process. We are looking glass of the patient behavior. Now we use terms behavior. What does mean behavior? Behavior is something objective. Behavior is something objective. Behavior is something which we can register via our sense organs or using special device and equipment like EKG, MRI, I don't know, functions, MRI, electroencephalography, and a lot of other things. Clear? Depressions, it's interactions. Now, what does mean depressions? It's interactions between psychological it's mean factors which mental process which depend our mental process. Social factors it's like etiology, because what does mean society? Society it's interactions between a different personality. What does mean personality? Personality it's a favorite pattern of behavior and thinking which unique in every individual and different in different individual. And this behavior stable in same situations and different situations. Okay, personality, like other things, it's interactions between mental process and behavior, because our mental process depend our behavior. Why our behavior very difficult? Our behavior very difficult because our mental process create a scheme how to do something in the environment. In our mind, we create like a sandbox in which we play in reality. We check a lot of strategy, and only after that we do something in the real life. Okay, now we come back from psychology to the psychiatry. Today I repeat once more our topic, depressions. Pay attention to these definitions. Depressions, it's a result of a complex interactions between social, psychological, and biological factors. What does it mean? It means that depressions, yes, of course, it's a diseases. Depressions, it's a syndromes. Depression, it's a diseases. But first place, depression, it's syndromes. We will discuss what symptoms depend depressions. What's different between what does mean syndromes? Syndromes, it's a set of symptoms which has a same pathogenetic roots. Clear? I repeat once more. Sometimes we use terms. Diagnostic criteria. What does mean diagnostic criteria? Diagnostic criteria, it's something like a set of a set of symptoms which has without same pathological mechanism. For example, it's a statistic. It's a statistic. Diagnostic criteria, it's a statistic. It's mean in some diseases we has list of some symptoms, but we don't speak about connections. Diagnostic criteria in general, it's a descriptive psychopathology and descriptive point of view. It's mean we only set the present fact. Okay. And depressions, yes, of course, it's a syndromes which has three roots. First roots, it's a social. Second root, psychological. Third root, it's a biological root. Three factors which create depressions. People who have gone what psychological event usually developing depressions? It's like a bereavement, psychological trauma. It's some incompatibility between a reality and internal worlds. It's like an incompatibility between internal worlds which present in our mind and reality which present around ourselves. But I pay you attention. A lot of people has incompatibility between reality and internal worlds. But only 1 or 2% in populations has depressions. Why it's happy? Biological background. Depressions developing if person has some biological vulnerability. Okay, let's go. Depressions, epidemiology. Some words about epidemiology of depressions. Again, women has depressions much more often. Maybe 2 women till 1 man. Age of onset. Now we speak about major depressive disorders. I pay attention. Major depressive disorders, it's not a syndromes. It's a diseases. It's a name of diseases. Usually near the 22 years ago. Bipolar disorders, it's other diseases which has depressions like a favorite symptoms. Near the 25 years ago. And dysthymia from teenagers till 31 years ago. Dysthymia, it's like a chronic depression. Okay, I repeat once more. Very important fact. Ratio between men and women. Men, two women, 2 women, 1 man. Second, onset age usual, it's 32 years ago. Bipolar disorders, 25 years ago in more young age. Dysthymia, my opinion, from teenager till 31 years ago. First, depression has a very high level of mortality, but mortality not due general medical conditions. Mortality due suicide. Um, every year we see that a lot of people do suicide in the world. A lot of people. It's much more than from some somatic diseases, and suicide is a second leading causes of death in young age. Clear. Suicide, it's a very serious medical problems. It's a very serious demographic problems. And very often who do suicide? Suicide do person which has a depressive disorder, so person which has a mental diseases. Mental diseases usually starting in the young age. Now we will discuss about diseases which include depressions like favorite symptoms. It's a list from the DSM-5 diagnostic criteria. Diagnostic DSM-5, it's our future. I think after 5 years we will use ICD-11 and DSM-5. Today, focus of our interest in it's major depressive disorder, single or recurrent episode, maybe dysthymia, depression due other medical conditions, and other specific depressive disorders and unspecific depressive disorders. Reading. Okay, etiology of depressions. Major depressive disorders. It's a biological vulnerability with some external event. Dysthymia. It's my opinion. It's a complete. It's more biological factors. It's mean chronic depressions which persist very long time. It's a depressive mood more than 2 years. Substance related. It's mean patients use substance and other medications and has depressions. Premenstrual dysphoric disorders, very often case, but it's a this period present in women not so long time, only before in some period. Depression due other medical conditions, we touch this topic today. Other specified depressive disorders I explain, and unspecified depressive disorders I explain these topics today. Okay. This now we will discuss about main diseases which we discuss in psychiatry. It's a major depressive disorders. We have some groups of criteria. For take diagnosis, we need to recognize 5 or more criteria for follow-up symptoms which persist more than 2 weeks period. And must be present 2 very important diagnostic criteria. First, it's a depressive mood and a loss of interest. Clear? 2 important diagnostic criteria which you must recognize. Depressive mood and loss of interest in. Maybe one of the symptoms. Sometimes patients cannot recognize that he has negative mood. Negative mood, it's like a pain. It's like a pain inside your soul. Clear? Sometimes patients said, okay, I have a bad mood because I have a lot of problems during their life, and he not recognize bad mood like a symptoms. But loss of interest and loss of pleasure, patient recognize very good. Why? Because patient feels that now money not so interesting, sex not so interesting, a lot of things not so interesting for himself. And very important remarks. These 2 symptoms must be present without connections with other medical conditions. Clear? It's mean chronic pain, other disorders. No. Patient in general has perfect health or problems with his health, don't touch connections, his mood area. Maybe some diseases. For example, after flu, patients very often has depressions, but it's not a depressive, major depressive disorders. It's depressions due general medical conditions because after infection diseases. Okay, now from this picture you remember 2 main symptoms: depressed mood and loss of interest. Next, are groups. Now we must recognize, now we discuss about main criteria in depressions. What's main criteria in depressions? It's a depressing mood or irritability, most of the day, nearly every day. It means then depressions, it's not a situations when you wake up in the morning and has a bad mood. No. Depressions, it's a very stable conditions. And not only bad mood. Now in the diagnostic criteria present irritability. Irritability sometimes it's a favorite symptom. Patients don't feel negative moods, but patients feel irritability. Sometimes these symptoms disturb patients much more than negative moods. Sometimes patients feel sad or empty feelings. Usual patients said, I don't feel anything. I don't feel myself. I don't feel my soul. I don't feel environment. I live like I'm empty inside. Inside myself, I'm empty. It's very specific symptoms. Sometimes the symptoms in old classifications we recognize like I forgot just a moment. Derealizations, depersonalizations looks like. Next, decreased interest and pleasure in most activity, most of each day. It's mean what pleasure? Patients feel pleasure due promotions in company. Patients have pleasure due relations with family. Patients have pleasure due relations with somebody. And patients lost interest in. He has interpersonal contact, but he don't understand why he do these things, because absent emotional reply, because he's like empty, clear. It's a very sensitive symptoms. For recognized depressions, you must recognize one or two from these symptoms. Next symptoms. Change weight and change appetite. Sometimes maybe increasing appetite, sometimes maybe decreasing appetite. It's in specific symptoms. In all classification, we have atypical depressions in which appetite increasing and typical depression appetite decreasing. Now we don't speak about this. Now we discuss about depressions. It's one nosology in possible increasing appetite, possible decreasing appetite. Problems in sleep. Problems in sleep, it's a insomnia or hypersomnia. It's mean a lack of sleep or oversleeping. Yes, of course, in all classifications, very often we meet an insomnia, initial insomnia. In new classifications, possible insomnia, possible hypersomnia. I pay attention. New diagnostic criteria more soft. More peoples can satisfy, more patients satisfy these diagnostic criteria, and as a result, levels of depressions be increasing. Why level of increasions be decreasing? Because our frontiers, our diagnostic criteria more soft. Change activity. Very interesting. In all classifications, depressions was a psychomotor retardations. But now you remember we added irritability, and now we added psychomotor. Okay, irritability, it's activity, and as a result, when we speak about activity in depressions, and in depressions, it's not only a bad mood. In depressions possible, for example, in depression possible irritability. In bad mood, yes, of course, it's a retardation psychomotor, but in irritability, it's agitations. It's like elected patients. Next, very interesting and very favorite symptoms, it's fatigue and loss of energy. Maybe it's a first complaints which has a patient. Like he don't feel pleasure, he don't feel himself, he has a loss of energy. He says, I'm like a lazy, I don't anything interesting for me, I don't want to do anything, I have not energy to do everyday things. Other criteria. Other very interesting criteria, it's guilty feelings. Patient feels that his guilt in some problems. It's mean usual you think that everybody guilting in your problems, yeah. But patients in depressions reflect everything to the himself. He thinks that he is the root of problems. Ask low self-esteem and guilty feelings. It's a very sensitive diagnostic criteria which we can use for take diagnosis depressions. Concentrations, concentrations of attentions. Sometimes it has connections with sometimes it has connections with mental activity, because loose concentrations decrease cognitive activity. Cognitive activity, it's not like a dementia, it's level so low, but patient decrease activity. Patients with difficult can resolve easy task in a job, in everyday living. Next, very important diagnostic criteria, it's a suicide ideations. Patients very often think about suicide and do plan how to do suicide. It was A criteria. You remember that in A criteria we must recognize some symptoms. B criteria. The symptoms causes clinical as a significant distress of impaired in social, occupation or other important area functions. Yes, this A criteria influence to the everyday living. Clear? Next, depressions, it's a mental diseases. It's mean must satisfy C criteria. What's criteria C? Criteria C, it's mean without general medical conditions. It means that it's not attributed with use of the substance or other medical conditions like a chronic pain, like a flu, like a period of reconvalescence after flu. Criteria A and C. Depend major depressive disorders. For bipolar disorders, we need episode of mania. I pay you attention. Conditions that may be mimic or coexist with major depressive disorders. First, substance abuse causing depressive mood. It's mean drug, alcohol. Chronic users of the psychomimetic drugs and alcohol, legal and illegal drugs, very often has a diagnostic criteria like from A groups, but this patient not satisfy C groups. Yes, B and C groups because present other medical conditions. Medical illness causing depressions. A lot of illness. It's a chronic pain. It's disorders which check some problems with hormones. Other psychiatric disorders. Mania, hypomania, bipolar disorders, schizoaffective disorders, schizophrenia. These diseases sometimes it's not depressions, but in schizophrenia very often present apathy. Apathy looks like a lack of energy, and you can recognize flatness effect and lack of energy like depressive syndromes. Yes, of course, in schizophrenia present other specific symptoms. We never take diagnosis depression if patient has a diagnosis schizophrenia. We never take diagnosis major depressive disorders if patient has a mania or a hypomania and bipolar disorders. Bereavement problems. Yes, bereavement problems. If before 6 months, it's not a depression. After 6 months, yes, of course, we can speak about depressions, because 6 months it's a bereavement disorders. After 6 months, same symptoms, it's a depression. Okay, I hope now you understand substance abuse, general medical conditions, mental diseases like mania, like hypomania, bipolar disorders, mixed episode, schizoaffective disorder, schizophrenia, um, can can show diagnosis like in the major depressive disorders. But it's a two different diseases, clear. It's only syndromes. Major depressive disorders, it's a poor depressions, it's a clean depressions without other symptoms, other mental diseases. Now we will discuss about level of depressions. Very, very bad mood, severe depressions. Uh, Mild or moderate depressions, it's mean not so difficult depressions. Level of functions, my opinion, level of functions depend level of severe depressions. Normal or balancing mood. Opposite, it's a hypomania, it's a mild or moderate mania and severe mania. What's different between hypomania and severe mania? In hypomania, patient must can live in society. In severe mania, usually he need hospitalizations because absolutely inappropriate behavior. Mild depressions. Now we discuss about diagnostic criteria of the mild depressions. What does mean more? It's a four symptoms from groups are clear. It's a four symptoms from group A, but must be present first one of the or two from first symptoms. How long time it's mean be present? Day-to-day functions. It's mean every day. And these patients can living in society. These patients can do satisfy everyday duty. But what's problems? These patients feel distress. This patient has a low quality of life. In up-to-date protocol, present reference and patient can we can manage patient without medications, only psychological treatment. But yes, of course, much more better if you combine medications with psychological treatment. In these situations, result much more better. Okay, I repeat once more. What does mean mild depressions? Mild depressions, it's a patient has four symptoms from A groups. It's mean one or two symptoms from begin groups. It's like negative moods and no interest in, and two other symptoms from other A groups. Symptoms persist long time, but patients has social functions. Next, moderate depressions. It's a diagnosis. Clear? It's diagnosis. Diagnosis of moderate depression may be suggest of the that both core symptoms are present. It's mean bad mood and loss of interest in, and more than four symptoms from other groups. These patients can solve problems, but he has a serious problems with resolving problems and concentrate attentions. His behavior, he need medications. He need medications, and but he can living without hospitalizations. He can living, but level of functions dramatically decreasing. Severe depressions. Severe depressions. It's has most certain. It's include two core symptoms. It's mean what's core symptoms? Lack of interest, loss of interest in. It's ahidonia and bad mood. And most in not all of the related symptoms. And majority of symptoms from other groups. Patient has a very rudimental activity. In these depressions, patients feel every time negative emotions. He cannot satisfy everyday functions. guilty feelings present, low self-esteem, suicide ideations, a lot of like these symptoms. I pay attention. These patients very often need hospitalizations. Why? Because high chance of the high ratio of the suicide. Now we discuss about depression due and other medical conditions. Majority of neurological disorders associate with depressions, but we don't take diagnosis like depressions for these patients. Clear? Yes, of course, its patients has depressive syndromes, but his main diagnosis is Parkinson diseases, Huntington diseases, cerebrovascular accident, vascular dementia, brain injuries, multiple sclerosis. A lot of these diseases include depression like symptoms. You can recognize, you can take diagnosis like moderate depressions, like mild depressions, maybe severe depressions, but pay your attention. It's not a major depressive disorders. It's a depressions due to other medical conditions. Clear? Your diagnosis depression due to other medical conditions, and main diagnosis like Parkinson's diseases. I hope you understand feature in classifications. Now we discuss about ABC of treatment. First, it's a psychological treatment. Psychological treatment for mild depressions. It's like a first line. But we can combine in mild depressions, we can combine moderate, we can combine psychological treatment and medications. In general, we can use psychological treatment not only in mild depressions. We can apply cognitive behavior therapy for patients with severe and moderate depressions in combinations with medications. Antidepressant drugs are very effective for treatment moderate and severe depressions. But not first line for case for treatment mild depressions. Mild depressions, I repeat once more, it's like something decreasing mood, its functions in general present but low quality of life. First line of treatment, it's a SSRI, fluoxetine, paroxetine, sertraline. I ask you remember these rules. First line of the medications of depression, it's SSRI. I pay attention. We can use SSRI for treatment not only depressions like in major depressive episode. We can treatment depressions during other medical conditions like symptoms of depressions. We can treatment due SSRI. How long time? Long time, at least 20 weeks, near the 20 weeks of medications. Usual patients reply to medications after 6 weeks, but after that we need more than 20 weeks maintains medications. What does it mean maintains medications? Maintains medications, it means symptoms absent, but we continue treatment. Why we do these things? Because after depressions, when we resolve depressive episode, patient has a very high risk of the return symptoms, and as a result, maintains treatment, reduce chance for return depressions once more. Now we will discuss about clinical case. Reading this clinical case. First, 45 days, 45 years gentleman has depressed mood. I pay attention. Depressed mood, it's from patient words. We never trust to patients. We must ask patients what's happy with him. And patient describe decreased libido. It's mean not impotention, no. He lose interest into women. He lose interest into sex. Function present. He wake up early in the morning. Okay. First symptoms, loss of interest. Second, insomnia. A lot of mistake in office. It's a problems with attention. Yes. And Speak with both about own worthless, guilty feelings, and this patient without psychiatric history. Okay, we has one symptoms: depressed mood, like a bad mood present, decreased libido. It means patient has a loss of interest in. It's a two main symptoms. After that, patient's insomnia, concentration in attention, problems in concentration in attention. It's the next symptoms, and self-esteem. Yes, problems with self-esteem. Okay, we has more than four symptoms. It looks like moderate depressions. It's not a severe, it's not a mild, it's a moderate depressions. And first episode. Why first episode? Because patient has without psychiatric history. I pay attention. Absolutely same patients. But what's different? Same symptoms, but 2 years ago he has a mania. Mania, it's an elevated mood. If patient has a mania and now he has a depressive episode, our diagnosis is bipolar disorders, because bipolar disorders, it's a diseases which has a combination between mania and depressions. If patient has 2 years ago he has a depressive episode, we take diagnosis major depressive disorders, recurrent episode, clear, recurrent. Because why major depressive disorders? Because patient has one depressive episode and second depressive episode. Why bipolar disorder is very important like a diagnosis? Answer very easy. Because if patient has bipolar disorders, we never use antidepressant agents for treatment. Yes, of course, first episode we using antidepressant agents, but usual antidepressant agent shift patient in mania. If patient jumping in mania, we understand it's a bipolar disorders, and we start to use mood stabilizers and atypical antipsychotic for treatment these patients. Next clinical case. Same patients, absolutely same patients, but 2 years ago he has a stroke. And yes, of course, once more we change diagnosis. It's other specific depressive disorders. Why? Because some times ago he has diagnosis cardiovascular accident. And in this situation, it's not a bipolar disorders, because he has like a general medical background or which can depend depressions. It's a stroke, yeah, and we change. What's conclusions from this picture? Same symptoms, but different history and different diagnosis. Please understand, our diagnosis it's not our diagnosis. It's not it's a process. Our diagnosis depend not only from current symptoms. Our diagnosis depend from the history of the patients. Thank you very much for your attendance. Thank you very much for your attention. I'm Alexander Dvirsky, Professor of Psychiatry. Goodbye. Now I finish broadcasting.